name is Cassidy Griffith, and I'm a Oncology Dietitian. So an Oncology Dietitian primarily is going to be consulting with patients, following up with patients, that kind of stuff. There is a community outreach aspect to it. I've been here since September, so we've not really reached that point yet because I'm still trying to catch up a lot with the patients that haven't been seen because I'm the first dietitian here. So there wasn't anybody here prior. A dietitian in general, so there's actually 3 branches. So there's a community branch, so that's going to be your dietitians that are in like doctor's offices, clinics, that kind of thing. They also can be found at extension offices. A sports dietitian falls under a community scope, and I also do over here, although I'm more so in a clinical aspect with this stuff because I'm mostly dealing with sick people. So I'm kind of a mix of the community because I'm an outpatient setting, but I do a lot of clinical work, and clinical primarily you're going to find in the hospital. So in the hospital, they're going to do things, which I do as well, with like tube feeders. They're going to calculate how much they need calorie-wise, protein, fluids, all that stuff. Some stuff they do micronutrients, so like vitamins, minerals, that sort of thing. But they will deal with TPN, which is nutrition through the veins. So that's a little bit more complex in that sense. But in general, diet educations, that kind of thing. If you have renal, kidney issues, or if you have diabetes, that kind of stuff, we'll sit down with you and talk you through the disease state, what kind of food you need, why you need it, that sort of thing. And then there's food service. So anywhere there's mass groups of people that eat, there's generally a food service dietitian. There's dietitians on cruises, there's dietitians in jails, obviously hospitals for food service in, because there's the cafeteria. They're doing a little bit of a clinical aspect because they're designing diets around disease states. And then there are dietitians in like big hotels, that kind of thing. Any kind of food chain, they have dietitians. I had no idea what a dietitian was. Most people don't. I tell them I'm a dietitian and they're like, what? So whenever I was a senior in high school, I was registered to start my orientation as a nursing student. And my mom, who is a nurse, told me what a dietitian is. And I thought, well, that's it. That's what I want to be. So I switched it that day. I was always interested in nutrition growing up, so it just perfect fit. So honestly, dietetics is way too complex. It's kind of silly how they have it set up. But you have it's a 4-year degree. Soon it will be for a master's. So that's something most dietitians are a little upset about because we don't want people to have to go to school that long. But there are programs set up that makes it a little easier. It doesn't matter what your master's is in. It could be in underwater basket weaving, whatever, as long as you have that bachelor's in dietetics. And what that looks like is 2 years of undergrad, and it can be kind of intense. We're taking a lot of the same classes some of the pre-med students are taking, like gen chems and physiology, that sort of thing. Then you have 2 years of your nutrition classes and your dietetics classes. There's 2 degrees. There's human nutrition and there's dietetics for dietetics and human nutrition DHN classes. So the human nutrition is generally more of you're going to a graduate school, like you're going to be a dentist, a pharmacist, a doctor, that sort of thing. So if you're interested in being a doctor or something like that, I would recommend doing that because it's going to be a lot more consistent with learning about humans rather than doing a biology degree or something like that. So that's a little tidbit in there for you. But with dietetics, you have to have an internship. So they're a little bit different with some of the undergrad classes that they do, but our nutrition classes are the same. So you learn the same stuff pretty much. But with dietetics, you have to have an internship. And to sit for the board exam, the RD exam, registered dietitian, you have to have an internship. So UK has a CP program, coordinated program, which is what I did. And it's kind of a fast track. You do your internship while you're in undergrad. Other students go through a program called the DICAST program, and that's where it gets really complex because you have to apply to all these programs. You might not be in state, you might be, or you could apply to a program like Iowa. You get in, you find your own preceptors, and you could be within your hometown because you found 3 dietitians to do your food service community and clinical rotations, or you could be driving and stay in a state over or something because you can't find a preceptor. But I'll tell any of your students that we have all 3 covered here. Right here we have an oncology rotation you can do for community. We have a food service rotation in the hospital and a clinical rotation in the hospital. So if anyone in Eastern Kentucky is interested in being a dietitian, we got you covered. And there's quite a few programs in Kentucky too. There's UK, EKU, WKU, and there's Cincinnati, so it's close. But there's a lot of dietitians in Central Kentucky. There's not many in Eastern Kentucky, so we have a big need for it out here. So it's definitely a growing field. We're gonna have a lot of new jobs opening up, and we have a lot of jobs open right now. So definitely a good field to get into for around here. So if you like to learn and you like to help people, this is a very good field for you because there is so much to learn. Nutrition is growing a lot. There's a lot of research out there. A lot of dietitians who are older, especially in our region. We have mostly older dietitians. They're not up to date on a lot of the research. So if you like to learn and work hard, this is a good field because you can do a lot of good. So from a general standpoint, most dietitians don't enjoy food service as much. There's a lot of money to be made in food service, so that's usually, money talks. In clinical, whenever I was in the hospital before, I didn't enjoy having so many patients who did not want to listen. So you get a newly diagnosed diabetic, they're very non-compliant. They're a diabetic because they're non-compliant. So I don't enjoy that because I care a lot about people and I want to help them. And if they don't want to help themselves, no one's going to be able to help them. Over here in the cancer center, though, I have cancer, I'll do whatever you tell me because I want to get better, So that's something I really like about my job here in the cancer center. That's one of them. I really do. I enjoy most things about my job. I enjoy the people I work with. I enjoy the patient population that I serve. A lot of people, whenever I tell them I work at the cancer center, they say, "Oh, that's so sad." I'm like, not really. I'm watching how many people get cured of cancer every day. I mean, we have a bell out in the infusion room that you ring whenever you're cancer free, and I get to hear that. That's pretty cool. Yeah. So it's not a sad job to me. It's a happy job. It's pretty cool. So the biggest negative with being a dietitian now is in 2024, they're going to require you to get a master's degree. So in order to be a dietitian, you can't just go for 4 years now. You're going to have to go in that extra debt or work those extra hours to get a master's paid for. I recommend trying your best to get scholarships, grants. There's a million scholarships out there that you can apply for. Most of my school was paid for, and that was a blessing. But start saving now, whatever age you are. It doesn't matter if you're a senior in high school or you're in 7th grade, whatever. You can do little things and start saving if you want to go to school. Try to stay out of debt, because that's going to be a big thing for just life. But also with the master's program, if you can get into a coordinated program, if you want to be a dietitian, that's a huge thing, because that's going to keep you from, internships in general, they usually cost around $10,000, something like that, because you're having to pay for a living and you're having to pay to move, and it's a big hassle. But CP, especially through UK, I don't know about other places, I'm sure they have similar programs. We have a program called AHEC that pays for housing, and that's a huge blessing. So our whole, you pay tuition, but our whole internship is paid for pretty much, and you don't have to worry about housing. They find it for you. That's a big aggravation for an area you're not familiar with. So I would say if you're going to go into dietetics, try to find a school that has a coordinated program. And once that 2024 stuff rolls around, which as of right now we're in 2022, so it will be that way for any of your students, I would say look for a school that has a CP program in their master's. And in general, most schools, they're going to be a little more willing to accept people into their own program that's been at their school for the undergrad. So that's something to kind of keep in mind. But also that debt thing is a kind of thing to keep in mind. So if you can try to stay out of debt, if that means avoiding a CP program that's out of state, which we have one at UK. So, but I think Cincinnati has a CP program as well. So that would be the biggest thing with dietetics, is try to get in that coordinator program. As a dietitian, my daily rundown, I do my census, so I'm screening patients. Over here, I mostly focus on weight because weight and cancer are very highly correlated for outcomes. So typically as people lose a lot of weight, they tend to get malnourished because those go hand in hand. Malnutrition and cancer outcome, they're very strongly correlated. So if you get severe malnutrition, your chances of death are very high, inpatient admission, all that kind of stuff. And that's what we want to avoid. We want you to feel good and all that stuff. So this is my assessment sheet. So once I go through and screen my patients, but I put all the patient information, name, date of birth, that kind of stuff to keep up with them, their age, sex, weight, that sort of stuff. And that I use their height and their weight to calculate their needs for the most part. There's other equations and stuff. I use a kcal per kilogram. So that's what's recommended for the cancer population. And I get my recommendations from this big fancy book here. And this has most of my recommendations. It has stuff for each type of cancer and all that stuff. So there's definitely research to do, and there's more outside of this book by all means. So also another thing that I look at is with medications, their food and drug interactions. So here's a little fancy book I have that if they're on a medication, I can go to and look at it and see if there's any kind of diet precautions that I need to recommend. A lot of medicines you can't have grapefruit with it because they conflict each other and it can make the drug not work. So there's little things that can be huge. Usually the pharmacist covers that with them, but it's a good thing for the dietitian to know as well. I have some resources for the patients if they ever want copies of it. So this is a cancer treatment and cookbook. It also has a lot of other tips in it about like exercise and that kind of stuff. So if any of you all have any family members or anything that have cancer, this would be a good thing for them to get. But you can, I think I got it off of Amazon, so you can find it. But that's a good thing for anyone that you know. And then one of my favorite topics, this has a lot of biochem in it, but it's a resource I use sometimes. One of my handouts that I'm going to send for you all to look at is a treatment starter packet I give to my patients. Typically I give this to them whenever they're going to start chemo, but a lot of it can go with radiation as well. So it just goes over a few things. One of the common ones that's kind of weird for patients is taste and smell changes. So there's some tips that I have for them, and I'll send you all. There's another packet. I don't think I have it in here. Remind me to put one in here. Oh no, I do. It's right there. So taste and smell changes, that's another one that they get that's kind of funny and I can help them with, and usually they're very grateful. I have one in here about the benefits of exercising cancer, so staying active. Used to the recommendations were just a rest, and now we actually encourage them to stay active. Nausea, vomiting, diarrhea, constipation, that kind of stuff, dry mouth, sore mouth and throat, that sort of stuff. That's something that can happen, and they seem like little things, but whenever you're going through cancer treatments and you have a decreased appetite and you don't want to eat, something as simple as a dry mouth can be the difference between you losing 30 pounds or not, because you just are that much more motivated not to eat. And then also with especially stuff like breast cancer or hormonal cancer, prostate cancer, that kind of stuff, mostly with breast cancer, I focus on post-treatment weight loss because there's a big correlation with weight, which actually itself, being overweight, can be a carcinogen, so it can increase your chances of cancer. So with those patients, after they're done with treatment, during treatment we focus on weight maintenance. After treatment we focus on weight loss to prevent them getting cancer again. I have some coupons in here for anyone that has any family members that needs that kind of stuff. And then, let's see, I have a tube feeding book, so this is something I give to my patients to go over, and it kind of gives them a little bit of an idea before they get their tube to kind of know, okay, I need to be aware of this and this. So with a tube, it literally is, it's just a tube that goes in your stomach. A peg tube is the one I mostly refer to. And it goes into your stomach, and it literally is just a tube that's hanging out there. They're really simple. They're very low risk. So if any of my patients could benefit from a tube, especially upper cancers, so like mouth, esophageal, or gastric esophageal cancers, I really encourage them to go ahead and get a tube. If they have issues with their stomach specifically and they can't tolerate a feeding in their stomach, then we'll put it a little post stomach, so we'll put it in their small intestine, and we can put it however far down we need to. So there's a lot of different types of tubes just because of the location, but they're all just a simple tube. So there's two types of feeding. There's continuous and there's bolus. So bolus is, if you all have had any kind of classes where you learn about the mastication, chewing, and as soon as you chew your food up, it becomes a bolus, and whenever you swallow it. So whenever we give a large feeding at once to replace like a meal per se, that's a bolus. If they're on a continuous feeding, they're either having their tube feed hung to drip, or they're on a pump. Most patients are going to be on a pump. That's going to be how we give it. If they have any kind of post-stomach, we do continuous to avoid blowing up the small intestine, and it can blow out the small intestine if we did a bolus too large, and not good. So we avoid that. But they are very simple, and they can give them different ways. They can hold it up and they have like a little cup on it and they can pour it in, or they can do it with a syringe where they draw it and then they give it in that way. But they're not as scary as people think. And you can eat if you have a tube. You can still continue to eat orally and drink and all that stuff. Sometimes I have patients that get them and they don't use them a single time. So they're not that big of a deal. People overthink it. But they absolutely can avoid death, inpatient admissions. They can prevent malnutrition, all that stuff. Can I give an example?
Yeah.
We got time? Okay. So I have one patient right now. He's a 6 foot tall male. His normal body weight was 150 pounds. This is our little case study. He was 150 pounds, his usual body weight. So this is February right now. In October was whenever he got diagnosed with sinus cancer. And he had a little pinhole-sized hole in his cheek. Within 2 months, this was a large hole, and you could see his tongue through his cheek. This is one of my worst cases, honestly. I mean, it's horrible. And the hole, this where the cancer ate his good tissues, it goes up toward his eye. His family is really concerned about him losing his eye right now. So he came to us. He was with a different hospital. He came to us, and we've started him on chemo and radiation. He's doing both. And we had ordered for him to get a peg tube and a Mediport. So that's where they would give the chemo through. And whenever we sent him, for some reason there was miscommunication and the surgeon didn't put the peg tube in. So we had to send him back. And whenever we sent him back, we found out that he had COVID. And because of the COVID policy, they put him off for 2 weeks, which really this could have been a life-saving procedure. So I wish they would have went ahead and done it, but they didn't. Within that 2 weeks, he lost another 20 pounds. He was 125-ish, somewhere around there. And this was in early January or maybe December. And then whenever we got him back, after that 2 weeks from COVID, he had lost another 20 pounds. He was down to 104 pounds, a 6 foot guy. I mean, skin and bones. He's the most malnourished patient that I've had. And so we got the tube in. And he's a very stubborn fella, like a lot of us Eastern Kentuckians. He didn't want to let him do the feedings the way that I'd ordered for him. But he did. He gained like 3 pounds in that time. This was just over a weekend. He got the tube on Friday, and this was like Monday. So come Tuesday, whenever I was, kind of learning a little bit more about this, I went down the hallway and I made him give him feedings right in front of me. And I was like, you're going to let him do this. And he's gained quite a bit of weight since then. And he's doing a lot better. He's feeling better. He looks better. He acts better. And really, these tubes, they are life-saving. I mean, they've made a huge difference for this guy. Okay. So my next thing I have here, this is for everybody. This is a list of good fats, bad fats, and some that are kind of in between. This is something that I give everybody, so it doesn't matter if they walk in here and they're a hematology patient, which means they're just coming in for infusion for low iron or something like that, or if they are the sickest of the sick cancer patients. I give them this, and I very much stress it to them. And if, honestly, I would say make a copy of this one and give it to all the patients if you want to, or patients, the students. But that's, I mean, this is important stuff. I tell anyone if they have grandkids or anybody that's looking to have kids, anything like that, to make sure they switch this stuff, because these highly processed fats, they're really a lot of the reason why America is so sick, because they're just awful for us. And if anyone has any questions about that, I can go more in depth about it. But a lot of bad research went into the bad fats, and recommendations have been based off of really bad research for years. And then I have, this is one of my most used handouts for my patients. It's called Power Packing. I actually just remade it yesterday, so you all got the new and improved version of it. What it is trying to increase calories and protein without a lot of volume. Because a lot of my patients, their appetite's decreased, and they're not wanting to eat, they're losing weight, they need to gain weight. We also supplement with oral supplements like Boost, Ensure, that kind of thing. And there's different types, and I've got a paper for you all that has the different types of supplements on it you all can look at. But the Power Packing, one example of that would be if you're gonna have like a fried bologna sandwich in the morning. A lot of my patients, that's a pretty typical go-to for them. I tell them the way we could power pack it is we add butter to the bread. So we fry the bread, butter both sides on each piece. Whenever we fry the bologna and put it on our bread, we can put cheese on it while it's still in the skillet, put a couple pieces on there, and then we can use mayonnaise on it as well. So that's going to add so many calories and protein as well with the cheese and mayonnaise that it's like you were eating 2 sandwiches. Actually a little bit more if you did all of that. So that's what power packing is. And that's something that's very helpful. And patients usually like it because it tastes really good. And then I have the taste changing chemotherapy page, which I touched on a little bit earlier.